Good afternoon. So I'm going to talk on the medical management of metastatic pancreatic endocrine neoplasms. I don't have any financial disclosures, so I feel like I should disclose something, which is I thought there'd only be like 5 people left in the room. So I'll try to do a good job here. So Dr. Khan did a lot of my introductory work for me. So pancreatic neuroendocrine tumors make up about 3% of all pancreatic cancers. The incidence is increasing, primarily because we do a better job of finding them. They are from tissue in the endocrine system, so islets of Langerhans. 1/3 are functional, the other 2/3 are non-functional, which means either they don't secrete anything or what they secrete really has no activity. And so the prognosis for these tumors is dependent on stage, tumor differentiation, and then the proliferative index or the Ki-67 index. So generally speaking, median survival for stage 4 disease is 70 months, although there's clearly a difference in that prognosis based on the grade. Low-grade tumors have a 5-year survival of 75%. Intermediate grade, which is a Ki-67 index between 5 and 20%, has a 5-year survival of 62%, and then high-grade tumors or neuroendocrine carcinomas have only a 7% 5-year survival. I would mention that not all grade 3 tumors are the same. There are well-differentiated high-grade and then poorly differentiated. The poorly differentiated behave more like small cell cancers and are treated similarly. The well-differentiated are those that have a Ki-67 index between 20% and 55% and don't seem to respond as well to regimens like carboplatin and etoposide. So the primary management for metastatic disease is observation, but indications for treatment would include pain, symptoms from hormone secretion, high tumor burden, or progression of disease under observation. So we only have to get through these 7 different ways to treat it, and then we'll be out of here. So, what was that? And the panel, right, and the panel. So cytoreductive surgery, liver-directed therapy, somatostatin analogs, anti-angiogenic agents, mTOR inhibitors, chemotherapy, and then peptide receptor radiation therapy. So I won't comment too much on cytoreductive surgery other than to say that it is appropriate for patients with indolent tumors with relatively low disease burden. If you are considering resection of metastatic sites, you should need to include resection of the primary tumor, and often it is used in conjunction with other systemic therapies, including somatostatin analogs. These are the different liver-directed therapies. This can be a 15-minute talk all on its own, so I will save it for the 2019 symposium. You're all invited now. Right, James? Correct. Okay, good. So about 75% of pancreatic neuroendocrine tumors express somatostatin receptors, most commonly SST2. There are 5 receptors, and they are octreotide avid on somatostatin analog scintigraphy. There are 2 synthetic analogs that are available that we use in treatment. One is octreotide, and the second is lanreotide. These are highly active agents in patients with functional tumors, particularly VIPoma and insulinomas. I would say that when you use it with insulinomas, it can cause very profound hypoglycemia, so be careful. For patients with gastrinomas, PPIs are actually the preferred systemic therapy. So for most of the data that I'm going to present going forward, trials in neuroendocrine tumors have lumped together all neuroendocrine tumors. So that includes, for our purposes, typically midgut or foregut, midgut, and hindgut. Pancreas is a foregut tumor. And so a lot of this data has either had small populations of pancreatic patients or has been extrapolated. So the PROMID study was the first randomized study looking at octreotide in a long-acting formulation versus placebo, showed an improvement in time to progression of 14 months versus 6 months. But it's important, this was for midgut tumors only, so there was actually no pancreatic patients on this study. But when NCCN looked at this data, it was extrapolated to the pancreatic neuroendocrine population. The Clarinet study, though, which looked at 204 patients, had 45% of those patients with pancreatic tumors. The progression-free survival was not reached at the time that the study was published versus 18 months for placebo. There was no difference in quality of life and no difference in overall survival. Moving to antiogenic agents, these are highly vascular tumors. They frequently overexpress VEGF, ligand, and receptor. And the first study was sunitinib versus placebo. It doesn't have a catchy name like PROMID or Clarinet, but we know that it works. This was dosed at 37.5 milligrams as a continuous daily dosing. The initial study in the non-randomized treatment was the original schedule of 50 milligrams for 4 weeks on and 2 weeks off. So this one looked at continuous dosing, again showed improvements in progression-free survival, doubling it. This study was actually stopped early because of benefit. The response rate, though, was only 9%. There has been a trend towards improvement in overall survival, but this study allowed access to sunitinib after progression, and so some of that crossover may have affected the survival data. Common side effects are diarrhea, nausea, and vomiting. The mTOR inhibitors, about 15% of patients with pancreatic neuroendocrine tumors have somatic mutations along the mTOR pathway. And so the RADIANT study looked at everolimus versus placebo in 410 patients with only pancreatic neuroendocrine tumors, low grade and intermediate grade, showed improvement in progression-free survival, again doubling 4.6 months to 11 months, and a suggestion of improvement in overall survival. Again, this study also had a crossover design. The side effects are stomatitis, rash, diarrhea, fatigue, and infections. So I've heard of this drug, streptozocin. It's one of those that happened before my time. So the original data was started in the 1970s, showing a response rate of 60% with 5-FU and 35% with monotherapy. This was at a time where actually tracking patients on studies was not so clear, so there was some imaging, there was some physical exam, there was some laboratory studies, and Howard, other things. Chest x-rays, thank you. And so in the 80s, there was an ECOG study with 105 patients looking at a combination of streptozocin with doxorubicin or with 5-FU, and then a third drug, chlorotocin, and showed a response rate of 70% with doxorubicin. This data was difficult to reproduce, and using modern RECIST assessments, the response rate is probably closer to 40%. These therapies were certainly complicated by lots of toxicity that have, I think, precluded its use in the modern era. Dacarbazine is another alkylating agent with activity, first looked at in an ECOG study published in early 2000. This was a phase 2 study with 50 patients with a response rate of 35%, an overall survival of 19 months, but with substantial toxicity as well. So this brought us to temozolomide, which is an oral, more pleasant version of dacarbazine. And the initial interest was in combination with thalidomide, a drug that has anti-angiogenic properties. showing a response rate of 45%. That N of 11 is the 11 patients on the study who had pancreatic neuroendocrine tumors. There was a subsequent study of thalidomide by itself that has a response rate of 0%. And so it was thought that the majority of the activity from this combination was from the temozolomide. More recently, there's interest in the combination of temozolomide and capecitabine. In a retrospective study of 30 patients, there was a response rate of 70%, with a median progression-free survival of 18 months and overall survival, 2-year overall survival of 90%. The benefit of therapy does correlate with MGMT expression, and it was based on this data that ECOG 2211 looked at a randomized study of temozolomide and capecitabine versus temozolomide alone. This study is currently closed to accrual, and we're awaiting the results. Another regimen with activity is FOLFOX. There was a study with 31 patients with a response rate of 30% and progression-free survival of 14 months. This data is interesting because of the different studies. This is the only one that actually showed no difference in benefit between pancreatic tumors and non-pancreatic tumors. I will skip over this investigational looking at bevacizumab as well as cabozantinib and move to peptide receptor radiation therapy. This is a treatment where a radioisotope is attached to a somatostatin peptide that then can attach to the somatostatin receptor, taken up into the neuroendocrine tumor, leading to cytotoxicity. And this is a therapy that has been around actually almost 20 years now, with initial data looking at yttrium-90 as the radioisotope. There were a couple of studies based out of Europe that looked at this, showing a response rate around 30% and stable disease in the rest. But the more common radioisotope is lutetium-177, which has been used in Europe for a very long time. They have a registry of over 1,200 patients. The first 600 represented patients where they were doing the dose finding, and another 600 patients that have been treated both with gastroenteropancreatic tumors as well as bronchial tumors. This has shown a progression-free survival of 29 months with overall survival of 60 months. And they have a registry of about 360 patients that have GI neuroendocrine tumors. And in their registry, they show that for pancreas, the median overall survival is about 70 months. So the American experience is the NETTER-1 study, which was published in the New England Journal of Medicine this past fall. This looked at 229 patients with well-differentiated midgut tumors, randomizing patients to either lutetium-177 plus octreotide 30 milligrams or high-dose octreotide 60 milligrams. And in this study, the median progression-free survival has not yet been reached after 2 years of follow-up in the lutetium arm, and is 8.5 months in the high-dose octreotide arm. The response rate is about 18%. These are the Kaplan-Meier curves showing substantial differences in both progression-free survival as well as overall survival at the interim analysis. So the concern with the lutetium-177 is that there is toxicity. Distinguishing toxicity from the radioisotope versus octreotide alone is primarily GI toxicity as well as hematologic toxicity. And in the data that's been presented, there are pancytopenias and a rate of myelodysplastic syndrome of about 2%, 2 to 3%, that has been fatal in some patient and has developed within 2 years of receiving their therapy. So developing it sooner than they may have died from their pancreatic tumor to begin with. Based on the NETTER-1 study, the FDA approved lutetium-177 1 week ago. It is approved for foregut tumors as well, based on the experience from the Netherlands. It will be available at Yale starting in early spring of this year. There's probably going to be about a 4 to 6 week timetable to get it ready. Since we're at Yale, I'll talk for one slide on immunotherapy, which is that it has not been well studied in pancreatic neuroendocrine neoplasms. We know that the expression of PD-L1 changes as you get higher in grade. So the grade 3 tumors have high expression both in the tumor as well as the immune cells. But there is only one clinical trial that's currently available. So in conclusion, these are the therapies that we can use for metastatic pancreatic endocrine neoplasms. None of them have ever been compared head-to-head, and I think all of them should be considered as long as the patient's performance status would allow. Thank you for your attention. Have a great weekend.